Right, let's talk about TMACS. What is it? What does it do? And what do we use it for? So TMACS is the Troponin-only Manchester Acute Coronary Syndrome's decision aid. We use it to help us decide the likelihood that a patient with acute chest pain has a myocardial infarction. We should only use it in patients where we already suspect the diagnosis of an acute coronary syndrome. And then we can apply it to work out the probability of a myocardial infarction. Now, why do we need it when we've got troponin? Well, remember that troponin is just a blood test. To diagnose myocardial infarction, we need far more than a blood test result. We need to know about the clinical context. And there are many other important factors that we will take into account when we're assessing a patient, other than just their blood test results. TMACS attempts to bring in some of that information to help us to make better overall decisions than we would if we just used the blood test by itself. So we derived TMACS in a research study by using something called logistic regression, where we asked the computer to work out what the best combination of factors would be to decide how likely a myocardial infarction is. And the computer worked out that there were 7 things essentially that helped us to decide how likely a myocardial infarction is. The troponin was one of them, and that's a really strong predictor. So we need the troponin result for these patients. And then there are 6 other factors that we'll go through in future videos, all of which were found to be important for determining how likely it was that a patient had a myocardial infarction. Things like ECG ischemia and a few details of the patient's symptoms. So when we're assessing a patient with suspected cardiac chest pain, what we need to do is enter the troponin result and the details of these other clinical features, the symptoms, physical examination findings like whether they appear sweaty, and the ECG findings. Then the computer will calculate the probability of a myocardial infarction. Using that probability, the patients will be stratified into 4 groups. We've got the very low risk group, where there's less than 2% probability of a myocardial infarction or an adverse event within 30 days. And therefore, we'd say that that group can have a myocardial infarction ruled out with one test. At the other extreme, we've got the high risk group, where there's over 95% probability of myocardial infarction or an adverse event within the next 30 days. So we can say that we've pretty much ruled in the diagnosis of myocardial infarction, at least with a high level of certainty. And we can get on and treat those patients, refer them to the cardiologists, etc. In the middle, we've got 2 extra groups. The reason we have 2 extra groups is there's 2 extra things that we could do with patients in the emergency department who have a suspected acute coronary syndrome. The low-risk patients aren't quite very low risk. They still need a second troponin test, but the chances it's going to have an abnormality are very small. So they are patients we say are suitable for ambulatory care, and they can have their second troponin test in the emergency department 1 to 3 hours later. And then we've got the moderate risk group, where there's a fair chance it could be a myocardial infarction, and we might need to do a little bit of further workup even after the troponin. Some of those patients need imaging, for example. So TMACS stratifies the patients into 4 groups very effectively. Some go home, some go straight to cardiology and have the diagnosis ruled in. And then we've got 2 groups in the middle, ambulatory and our moderate risk group. So that's how we use it. It compares very well to other risk scores, such as the heart score. When we've compared it, it does better than the heart score. And we've used it in practice now for the last 8 years in central Manchester.